Opening session for the Virtual International Forum TB for TB 2022. Before starting, I would like to inform everyone that this session is being recorded and broadcasted on Zoom, YouTube, Facebook, and Canal Imagen TV from the UBC, Autonomous University of Baja California. As I was telling you, we have a YouTube channel in Spanish, which is Divulgare FWC, and another one in English, it's Remi TV. So now I will introduce all the speakers and all the members of the panel. Dr. Patricia Radilla Chavez. She's from the University of Baja California as Campus Ensenada. Thank you. Dr. Miriam Alvarez Mariscal, who's the head of the support department for the extension of education on art and vinculation, and also Dr. Verónica Lacabels, the site director of the University of Baja California Ensenada. Thank you, Doctor. Ms. Maria Sosa Salas, who's the head of the Academic Cooperation Department from the Autonomous University of California in Mexicali, on behalf of David Toledo, who is the General Coordinator of the Vinculation Department from the UBC. Thank you so much for being here. Dr. Fátima Luna, who is the Director of the Micobacteriosis of the Micobacteriosis Program, National Center of Disease and Control and Prevention Programs under the Mexican Ministry of Health. Thank you so much. Thank you for being here. Dr. Rogelio Zabalda Garibay, who is the Director of the Healthy Border from the Health Border Commission, Mexico, US. Thank you for being here. Good morning. Dr. Rogelio Hernández Pando, who is the Chair for the National Network of Tuberculosis. Thank you. Thank you, Doctor, for being here. Thank you all for being here, for taking the time to be here with us on the virtual international forum on TB. I'll pass the floor to Dr. Hernández Pando, who will give us some opening words. Thank you so much. Thank you, Dr. Muñiz. Well, it's a pleasure for me to be here. It's an honor to be able to welcome you all to this virtual international forum on TB 2022. This is a big event for everyone, for all of us here. It's a major event for us, and we had a very good agenda created by Dr. Muñiz with the collaboration of many other people who have actually contributed to this effort and in sharing their knowledge and expertise in this area. So today until November 22nd, we're going to have the chance to meet weekly and have these conferences, virtual conferences. And this will be very interesting for all of us that work in this area. And I'm certain that this will be consolidated as an international event worldwide. And we want to thank also the support from the University of Baja California for their support. Thank you. I wish you all a very productive session. Thank you, Dr. Rogelio. Now we'll pass the floor to Dr. Zapata Garibay, who is the Director of the Healthy Border Commission. Hi, good morning, everyone. Thank you for being here with us. On behalf of the Health Border Commission, I would like to tell you how we are very happy to be here on this third international forum on TB. For our commission, TB is a major issue, it's a priority issue for us. We have been working on this for the last 20 years. And a session in previous meetings with the different ministries of health across the border, we still see TB as a major issue for us, and we'll tell you later on the actions to be taken, that even all the ministries of health on both sides of the quarter, they're asking this health board commission to develop different actions to be taken in the future regarding TB. Thank you, Dr. Rogelio. Now we pass the floor to Dr. Fátima Luna, who is director of Micobacteriosis program. Hi. Thank you so much. Well, good morning, everyone. I want to congratulate ourselves for having this forum and seeing it grow and seeing it expand and become and consolidate. I want to thank all the team that has made this possible. We still have a lot of work to do, but we need to acknowledge all this big effort that is put into this forum. So we celebrate this kind of events. Dr. Muñiz, thank you so much for your continuous effort, and we'll continue working on our end. Thank you so much. Thank you, doctor. And thank you for the support, the non-stopping support from your part. So thank you so much. Okay, now we pass the floor to Licenciada Salas on behalf of David Toledo. Hi, good morning, everyone. On behalf of Dr. Guadalupe Toledo Saracino from the UABC, I want to say hi to Dr. Rosa Garcia Chavez, who is the director of the health of the Health School from the University of Baja California Ensenada. I want to thank Dr. Muñiz Arrasal and all the guests here. I want to thank all the presenters. I want to thank you all for making this possible. And thank you for making this virtually so we can reach more people. We know we are gathering very prestigious investigators who are going to be presenting all the outcomes of our researches with the world. So also we have people from all different levels of government and educational academies, similar organizations, so we can have an open dialogue and trying to work together and collaborate in the future so we can actually consolidate the impact against TB in our society. Thank you so much for this event. No, thank you. Thank you for your participation. Now, Dr. Miriam Alvarez Mariscal, is your turn. Thank you. Good morning, everyone. Greetings from Dr. Monica Maxenes Butramunen, who is the Vice Director of the University of Baja California in Ensenada. Also want to thank all our guests, Dr. Aparecida Radilla Chavez from the Health Science School, Dr. Saldas, who is the head of the Educational Collaboration Department from the UBC. Also, thank you, Fátima Luna, who is the director of the Micobacteriosis program by the National Center of Disease and Control and Prevention Programs under the Mexican Ministry of Health. Dr. Rogelio Zapata Garibay, who is the director for the Healthy Border from the Health Border Commission on the Mexican side. Also, thank you, Rogelio Hernandez Pando, chair of the National Investigation Network for TB. Also, our dear Dr. Raquel Muñiz Salazar, who is the chair for the Multidisciplinary Network for Research on TB, and general coordinator for the International Virtual Forum on TB. Also, all the panelists for their participation in this major event. On the UBC, we are very happy, very pleased to have in this kind of virtual events, international events, and of course, right now we're focusing on public health. And I want to mention that this forum has a direct impact on all the students, professors, and researchers, so they learn the latest discoveries and advances in technologies, diagnosis for TB worldwide. And as the specialist just mentioned, is disease that causes many deaths around the world. If we learn something from the COVID pandemic, is to optimize these technologies so we can broadcast all this information and create good communication with all the people. So the students, they have a chance to use all this knowledge, the knowledge being shared here, I also want to mention that this forum, the purpose for this forum is to reinforce superior education and research in health areas, particularly on TB. And I also want to, we also wants to support, we try to support information to the academic. I also want to congratulate all the organizers and all the participants for supporting all these initiatives so we can spread information on health science through this type of events. Thank you so much. No, thank you, Dr. Miriam. Now I'll pass the floor to Dr. Patricia Radillo Chavez, who's the director of the Health Science School in Ensenada. Hi. Hi, everyone. On behalf of the UBC, I want to greet everyone. On behalf of Dr. Emmanuel Valdez Dobladillo, I want to thank everyone for being here and all the different authorities that are here as part of the panel. This is a major effort because TB in Baja California has been a big challenge for the public, for public health, and there are always areas of opportunity. And this forum is targeted at public health care providers. So I just want to thank all and each one of you for all your effort, and also Dr. Raquel Muñiz for being the leader for this event, because we have had very good results and very good outcomes from these forums. The purpose for this forum is to generate a good channel of communication at the international level among healthcare professionals for prevention, diagnosis, and treatment of TB, and also contributed with the strategy for stopping TB, which was established by the UN and the WHO. And the purpose is to reduce by 30% of all the cases and deaths. That's to reduce 30% of deaths from TB and 80% of the incidence of this disease in our populations. It's a big challenge for everyone. Every death that we can avoid and every case that can be prevented is a major effort behind that. But I think that all the staff involved in all the different diagnosis, prevention, and treatment areas for TB is very valuable. This is the third edition for this virtual international forum on TB. And in each one of them, we had great participants. Around 2,000 people on the audience have been watching us and listening to us. Of course, Mexico, 80% of the people, the audience comes from Mexico. And the states that are more involved in this kind of forums are those that, by coincidence, have faced the biggest challenge for TB. Mexico City, Baja California, Veracruz, Chiapas, Guerrero, among others. The forum, as I mentioned, is targeted at healthcare providers and also to students. Most of them are enrolled through the biology, medicine, and bioengineering schools. So thank you for your interest, because all of you really help us to find better diagnosis for TB. I'm going to give you some numbers on how much TB impacts our society. And in 2020, around 9.9 people were infected by TB. 3.3 million were women. 1.1 million were children. 6 out of 10 people. Let's just measure the impact of TB on the population. All these people with TB, they have a comorbidity, and diabetes is the top on the list of comorbidities. So we translate into everyday life, a large portion of the population and around the world, they suffer from tuberculosis and diabetes, which increases the risk and the seriousness of the situation. And We also know that Baja California is the hotspot in Mexico with the largest number of deaths and cases of TB. Is well above the national average. It tries the rate of morbidity, the national morbidity rate. So in summary, Baja California has a bigger issue than the rest of the country, because we are right here at the border. This is where most people cross the border, and it also has other characteristics that play a major role for having TB here so persistent in our communities. So here in the right place to talk, to learn about the symptoms, to learn how to treat them, and how to prevent it. And also the latest advancements on technology to be able to achieve our goals. And also we'll learn how to come up with the best treatment for those drug resistant patients. So I want to thank all for being here. On top of this, also we need to consider that COVID-19 pandemic, it had two major impacts on the healthcare systems, because the occupancy at the hospitals at the beginning was very high, and also first course providers, they had to be reorganized, and it had a big impact on the timely attention for TB patients. So this is a big delay. It sets us back to heal or cure patients with TB, and also had an impact on the adherence of a treatment from the patients. So all of us here, we all play a role in this, so we can contribute on finding a solution to this problem. Without further ado, at 8:56 a.m. on today, October 4th, 2022, I officially open the Virtual International Forum on TB 2022. Thank you all for your efforts. Thank you, Dr. Patricia Radilla. And just a quick comment. I want to tell you that this channel is being broadcasted on is being streamed on Facebook, Tradate, YouTube, Divulgare, SS, and YouTube in English, and Remi TV, and also on the Imagen TV from the UBC. So we would like to welcome Dr. Francisco González Arrazar, who is a researcher for the University of Monterrey. And he will introduce the speakers. I'm very pleased that today's event, is being opened by Dr. Giovanni and Dr. Fátima. Thank you so much. And also, we need to mention that this event is a result of an effort by different organizations. UBC is one of them, the Health Board Commission, the CDC, and also the National Center of Disease Control and Prevention Programs on the Mexican side. Remi TV also plays a major role in this. So thank you, everyone, all the organizing committee. And now let's pass the floor to Dr. González. Yes, good morning, everyone. For me, it's an honor to be here. I want to thank all the organizers for inviting me here as moderator on this Virtual International Forum on TB 2022. And also want to congratulate all the institutions that took part in this big effort, such as Remi TV Network, and all the different institutions that made this possible. Thank you so much, and congratulations. To begin with, I would like to introduce you to Dr. Giovanni Migliori, who is the director of the WHO Collaborating Center for TB and Lung Diseases from the Maugeri Foundation, Tradate, in Italy. And he will be opening today's forum. So welcome, doctor. Now take it away. No, thank you so much, Francisco. Thank you, everyone. It's an honor for me to be here. Can you see my screen? Okay, perfect. Yes, today, the purpose, objectives are to review some existing definitions, discussing examples from different epidemiological patterns in different countries and their causes, and clarifying some myths from immigration myths that are not being scientifically proven, and to review the available interventions to stop and control TB burden among immigrants, and as well as identifying the problems that we face. Immigrants are all the people that move from one place to another, crossing an international border, and even within the same country, from state to state. In English, these people are called IDP. That can be translated as internally displaced people. We have people like such as Libya, and many people. These are a lot of IDPs that are back in their homeland after a few months of being in other countries and other areas. So all these people, these immigrants, they move or commute to different countries. They have different legal status, and they might have to move voluntarily or involuntarily for different causes and for different periods of time. So I think we're done with this definition of asylum seekers. Asylum seekers is a person that is trying to start in the process to ideally be acknowledged as a refugee. The problem is that many people, a lot of those people that seek asylum, so only a few of them can meet all the requirements for them to be considered as a refugee based on the international laws established by the UNHCR. Clearly, all the refugees initially they request asylum, but not all of them will get this status. Here I show you some images from here's the border with Mexico-US border. Here on the top left, you can see pictures of immigrants on the north of Africa traveling towards Sicily and just to the south of Italy. So here we have some groups, historically important groups here. This was well known that people from Latin America, Brazil, and the people in Europe and the US and Canada. You see some of this. You see there. We see how people move from all these areas from Asia to Europe, from Africa to Europe, and even some migration within the Russian territory. And today we're discussing the flow of people from from Latin American countries towards Mexico in order to cross to the US. So it's important for us in Europe to consider refugees in Ukraine. Today we have a very dramatic situation, a very dynamic situation, I dare to say, because a lot of these people are back now that this situation has been stabilized. A lot of women with kids are back in their homeland because they need to rebuild their family, bring their family together again, because the men were fighting in the war. So classically, we have 4 phases for immigrants. Phase 1 is before the departure, with all the problems that they may have, that create a need for migration, poverty, war, violence. And phase 2 is the travel phase. It's the travel conditions and mode, because these travel conditions can be horrendous and very dramatic with violence. And that's phase 3. We have the host community. This host community for the immigrants, with all the incoming problems, illegal issues, social, psychological issues. And also we have a 4th stage, which is in the return stage. It's when after months, even years, the immigrants and their families, they go back to their homeland. Globally speaking, we have 272 million immigrants. That was back in 2019, according to the migration report in 2020. That is 1 person out of 30. And we see here on the graph, 1 person out of 30 in the world is an immigrant. That's a lot. So we see this happens in all the countries, in all the continents. We have immigrants. So it's important for Latin America to consider all the immigration from the south coming through Mexico to the US and Canada. And in Canada and in Europe, we have the situation, the current situation in Ukraine, but also we have a lot of large flows of people coming from Africa, and they go up to the north trying to find a better life. So this is a very interesting picture. This is Croatia, Dubrovnik, which is a very interesting city in Croatia. Historically interesting. As you can see this building right here, we used to have the Dubrovnik quarantine building. This is the harbor, Dubrovnik harbor. We had a chain here at night. They used to have a chain here to prevent ships and boats to come into the harbor without being controlled. So this quarantine building, it's a building divided in 4 parts, 4 sections. It was kind of a hotel, kind of a hybrid between a hotel and a prison. And every day, the people on the boats, they would go transitioning from phase 1 to phase 2, 3, and 4, and so on. This was the first stage for them. But they had to stay there to make sure that they didn't have any diseases that could be transmissible for all the population in the city. So they have to stay there in quarantine. It's clear that there are many countries, there are many very low TB incidents, but we need to remember that a major part of the TB infections come from immigration. And also we need to remember that TB can be reactivated within the 5 years of the first contact with the disease. We have some data, very interesting data, that suggests that immigrants, they have a relatively low transmission in immigrant cities. Why? Because most of the immigrants in those cities, they need to live in clusters, and together they stay together and not only have the chance to transmit TB to the nationals of the country they are in. So on the historically controlled methods were focused on identifying reactive TB, active TB, and the yields for these were low. And now we have a new idea, having a more aggressive approach to also address the LTB cases. So this is a situation in England, in Wales, in the UK, where London City has a TB incidence much larger than all the other cities in the country. Here we can see this is the Greater London, the Greater London. Here the red spots, these are the areas where immigrants live. And in this area, we have the same incidence of TB is we have in New Delhi and in the cities of Pakistan. So it's the same incidence in London and in those countries. Very large incidence, that is. And also TB has an important burden on immigrants. But we have three main reasons for this. The first one is that some immigrants, they have active TB when they come in, but it's very rare. I think it's 35%, according to the literature. Most immigrants have a LTBI, and which is reactivated after coming into the country. And this could amount to 5 to 75% of the population, and is correlated to the incidence of TB in the country. And also age plays a major role. And also, as we mentioned before, local transmission is not very important. It's not major or significant from the immigrants to the non-immigrant population in those countries. And the mechanisms, we have two mechanisms. And the first one is reactivation of TBI, active or LTBI, and also an exogenous infection, a new exogenous infection. Also, the reactivation of this TB cases plays a major role when we have immune suppression, such as people living with HIV or any other kind of health condition. Also, people with diabetes, people who have kidney diseases, social, also malnutrition, it plays a major role for this. The abuse of alcohol, the use of drugs, and also we have when immigrants first coming into a country, they have some healthcare needs. They suffer from hyperthermia. Some people suffer from gastrointestinal diseases, complications on the delivery and pregnancy, diabetes and hypertension, and particularly women, refugee women and immigrant women, they have faced specific challenges. They suffer from sexual violence, and they have problems because some of them are pregnant, they have children. So it's clear that all the chronic diseases, they represent a risk for all the people with TB who interrupt their treatment due to traveling, commuting to another country. The problem here is that when patients come into the country and including these that are in TB treatment, they interrupt their treatment. Another issue is the problem with the settlement, because we have a problem with economic diseases, as we mentioned, due to acquired TB infections in their homeland. Some problems related to poverty, some psychological issues regarding to previous traumatic events in their lives. They are very common among immigrants, and also the access to healthcare for refugees and immigrants. This is a historical picture. This is a methodology for the screening methodology for TB and syphilis in Ellis Island, which was the door to the US. All the ships coming from Europe, they would come into the US through Ellis Island back in 1917. So if we had to then try to identify TB, and also syphilis, which was very transmissible back then. And on stage 3, they would have mental issues. So they would focus mainly on TB and syphilis and psychiatric disorders. Immigrants, with their bags, they would have to climb up a very steep staircase, and at the end of the stair, they would have the military would be here, some doctors and nurses, and they would need to screen people to see if there were patients with cough. They would evaluate it for TB, and patients who were aggressive in their behavior, who were too nervous, they would be screened for syphilis and mental disorders. This is a very archaic technology, but it's very interesting to see this from this historical point of view. Today, this is a picture that I took a couple of weeks ago in Lebanon, where we have refugees due to the Syrian war. And the thing is, the problem in these hotspots is to guarantee a good diagnosis for contagious cases to prevent the transmission of the diseases such as TB. And it's possible to organize an active screening with a survey for looking for symptoms, and when available, having a thorax X-ray, but it's not always possible. We understand that. A second possibility, of course, would be the diagnosis, microbiological diagnosis with microbiological testing. And today we have Expert Ultra. It's a little bit more sensitive and needs less biological matter, and also Expert Omni. The problem with treatment is we need to guarantee cases retention with these technologies. For the diagnosis and treatment of infections, we have a testing strategy using IZIGRA, TST IGRA. Also, obviously, these IGRAs have some advantages. But IGRA or IGRA is very expensive. It's more expensive. Definitely, we have a problem, financial problem for this, and also for treatment regimes. It's important to shorten the duration and reduce side effects. using regimens with rifampicins, such as rifampicin during 4 months, or also rifampicin isoniazid daily for 3 months, or the same scheme using, but administering weekly for 12 weeks. The problem with rifampicin is very expensive. It's not available in all the countries. For instance, in Europe, it's not available in Europe. So it's important to see how immigrants, there are some myths around us and there are some realities. Some of the myths are not scientifically proven. The first myth is that immigrant numbers keep going up. That's not true. And that's not true. It's actually going down. And Europe, in this case, it applies, maybe in other areas of the country, TB increases due to immigration. That's not the reality. The truth is that in Europe, in other countries, TB drops. Multi-drug resistant TB is increasing in the previous Soviet Union. And most of the people born in abroad, they don't comply with treatment, and that is not true. And also, the rates of TB by 2,000 people in the country are stable in immigrants. The other myth is that, as I mentioned, people born abroad, they don't comply with the treatment. That is not true. As it's not true that immigrants transmit the national population. It happens, but it's not a significant, that's not a significant percentage of people are infected through immigrants. This information is for 2014, but it's the only research we have at this level, thanks to So here we see all the European countries. In green, we have countries where immigrants are successful, a major success compared to those the people, the nationals in those countries. Yes, and Cyprus and the Czech Republic, Finland, Germany, and also Slovenia and Sweden. This does not apply in other countries such as Spain and others. So some countries are very successful. For example, in Milan, the Peruvian community, they have a 95% success rate, which is higher than even the nationals in Milan, because they have a very high adherence to the treatment. This is a very good example for a community that complies highly with the treatment. And also, we have other vulnerable populations that could be of interest. Obviously, poor people, the poor, because poverty is the right condition for the development or the transmission of TB. Only prisoners, indigenous populations, ethnic minorities. In Europe, we have Romanians, which is a very moving population, and it's very hard to control. Also, we have the homeless population, drug users, alcohol abusers, and children and the elderly. And we also have now a publication from the WHO, the WHO consolidated guidelines on tuberculosis. It talks about screening and the different modalities. We have immigrants are always recommended for screening, active screening, and needs to be done for active cases for LTBI, for LTBIs. And finally, I'd like to mention, we want to leave some messages here on the table so you can take home. Epidemiology, we have discussed epidemiology and all the different border crossing movements around the world. We see all the poor people moving up northwards, and we have different strategies, but we don't have a perfect strategy. We always have to consider the costs, the efficiency. It's hard to work with mobile populations. We had a discussion on the major problems for controlling TB in immigrants, and also the opportunities, the intervention opportunities we have, and the potential impact on the healthcare system. Today in Italy, we celebrate Saint Francesco, who is our saint in Italy. Francesco would say, first, we do what is necessary. He's speaking Italian. It could be translated as, first we do what is necessary, then we do what is possible, and finally, we work to make the impossible possible. I think this is perfect for this. This totally applies to TB. Thank you so much for your attention.
Muchísimas gracias por su excelente presentación, Dr.
Thank you, Doctor, for such a great presentation, Dr. Giovanni. Okay, now we open mics for questions. And now let's start with some of the questions we have right here. First question is, within the 4 immigration phases process, what's the best phase to work in or to approach the health status in an immigrant? Yes, what would be the best phase for us to intervene? I think they're all important. They're very important. Ideally, it's very difficult to have prevention of the causes that are the causes. We know the need for travel, because then we need to start fighting poverty. We need to fight war, violence in those countries, in those communities. So within SBG, we know the war against poverty, it requires a very long intervention. The travel, there's not much we can do there because, you know, they are moving, is their own initiative. What we can do, or that we do in the Mediterranean Sea, is that we help the immigrants, because many of those little boats don't work, and a lot of people die in the sea. So, and I think that phase 3 would be the easiest when they first come in. That's where we can screen them for TB. Can be cost effective, actually. There are different possibilities. And we can also create a budget, allocated budget for phase, for when they go back home. and it could eliminate some problems. I think the phase 3 is the best approach for us. Phase 1 or 2 and 4, those, I think those depend more on international organizations and different aspects that a country can do, but not us. So there's something very, very interesting here. In the past, we would worry about finding active TB cases within immigrant populations. But now the major concern is finding LTBI cases in these populations. So what are the detection strategies for latent TB in immigrants? Yeah, this is a very important question. How we diagnose the infection? We do it through the TST or with IGRA. IGRA works better than TST, but it's more expensive. And also use exclusion of the disease through the X-rays databases. In the future, things might change, but we're not in the future, we're in the present. And so this is what we can do today. We cannot start thinking about what technology can lead us. Maybe we have some genetic markers that will allow us to identify TB in this population. But there's something very interesting in the countries in the Gulf, that whether it's oil, Saudi Arabia, Oman, all those countries, they have a very low incidence. So the same incidence rates that we see in the US or in Europe. The problem in those countries is that they have immigrant population, sometimes 5, 7, 8 times larger than the local population. The local population is small, and they have so many immigrants. They're there to work on construction and other areas. So the project for eliminating is based on systemic screening of all immigrants for infections using IGRA. So this works. The problem is that some of these immigrants, they're in the country temporarily. In this case, clearly, it's not justified because we're not going to pay for intervention that is not going to be completed in the future. So, because maybe in a few weeks, the immigrant will move to another country or another area. So definitely, this is going to be the direction we'll need to follow. Yes. Well, yeah, all this is related to, particularly, I've been working on IGRA research and the diagnosis of LTBI cases more efficient with TST. And the question is that in this immigrant population, generally speaking, within this general population, there's some risk populations or risk, people with diabetes, obesity, or HIV. What would be the treatment strategies for these populations? And if any of these strategies are being applied right now? Well, this is a tough question because I think in all the countries, we have different technology. For instance, according to the WHO guidelines, the screening for TB, patients with TB is not recommended, but in Mexico, 40 to 50% of patients have diabetes, and so we need to do it anyway. So I think it's very important. to collaborate between to have collaboration between the HIV and TB organizations. Clearly, we need to solve comorbidities for chronic diseases so we can solve the problem of infection. So I think the initiative, we in Mexico we call, it's been work on. We need to have good collaboration among the diabetes clinics and the TB programs on both sides. So we need to consider to have better collaborations among the different clinics so we can provide healthcare to all these patients. We understand that Mexico is a large country with a lot of people with diabetes, and it's very hard. It's a very hard situation. Yes. And lastly, you mentioned that what I want to ask you, if you have used AI technologies for analyzing X-rays in these populations. And it has been approved by the WHO for TB screenings. In which countries that you know that this is being, that you know of, this type of technology has been used? Well, thank you for that question. Now, in all the guidelines from the WHO, all these computer-assisted techniques, they are recommended as the same as a human intervention. So AI works well and needs some more information. The software, the more information you put into the software, the more precise it will be. It works well, and it has a level that is similar to the radiologist examination. So this, particularly where it's hard to have X-ray specialist. So this is a very good tool in those instances. A pilot experience that I've seen in Europe was done using a program financed for the European community in Romania, in Bulgaria, with mobile units with last generation X-ray machines with the latest technology. This could be taken to different places. It could be used in the border, but it can also be used in shelters. So we can, once a week, this mobile unit can go there and do some screenings. Of course, you will need a technician that knows how to operate this technology. It's like a little truck, like those trucks back in the 60s and 50s. It looks like that, but with new technology, and it works very well. We have the same results as when we have a professional radiologist doing this examinations, these screenings. Okay. I think that more money should be allocated in other countries to implement these technologies. Which countries do you think would be benefited by this kind of technology? How can it be financed? Is that the question? Because, yeah, well, I think many of these pilot programs, they're funded for developing countries in Africa and India. The problem in Latin America is not many countries, they're not eligible for this. I think Mexico is not eligible because they're a little higher than the eligibility level. So unfortunately, the mechanism is not very flexible for allocating these resources because the focal point should be the donor who allows buying more technology and also allows the construction. It's perfectly possible for the Global Fund to build a lab and buy equipment for the lab. Usually, those donors, they don't like building and so on. So, but for Latin America, only a few countries are eligible for this, and that is a problem. For sure, it's not an easy situation. Yeah. And lastly, it's a personal question. For you, what do you think is needed in order to have a better control of TB in this immigrant population? What do you think? What would be your suggestions if you could do anything here, regardless of money or regardless of financial situations? What would you do to stop this problem of TB in immigrant populations? I'm going to answer to this question that also have some ethical implications, ethical and financial and analytical implications. So I'm going to tell you the 8 activities, the 8 activity for alignment approach, which is one of the people that have written this document mentioned that activity 1 is political commitment. That's number 1 on the activity. And activity number 8, the last activity, is international collaboration. So I think that particularly for immigrants, we need to have international mechanisms are necessary. Without it, a country can do something but cannot do much. If a country is in an area, they can, like you have this very interesting project with the US. It works well because the problem is, this problem affects both sides of the border. So it's clear that the rich country may try to stabilize and control immigration, but the best way to control the immigration is by helping the poor countries and invest in TB technologies and programs and fighting poverty in those regions, which is not easy. Because to fight poverty, you need to do more than just having a helicopter hover the cities and give away money. No, we need to, it's a problem that requires 10, 20, 30, 40 years of work and commitment. So I think rich countries have an ethical problem for helping poor countries. They need to do it in a coordinated fashion, coordinated with the needs and the priorities in the country. And most of the times, that's not the case. Okay, thank you, Doctor. Dr. Raquel Muñiz has a question for you. So I pass the floor to Dr. Raquel. Dr. Giovanni, thank you for your presentation.
Ahorita con respecto a lo que decía de...
Now, regarding what you just mentioned, how some countries are not eligible for the World Fund for fighting TB. This is a little weird or unfair because considering, for instance, Peru in Latin America, has the highest rate, and Brazil, which has half the rate as Peru, and I think Brazil is eligible. The national mean in Mexico is 20 cases out of 100,000 people, but Baja California, we have 60 cases out of 100,000 people living in the area. So we cannot compare the Mexican rate only considering the national mean when Baja California is showing rates 4 times as large as we see in the rest of the country, and even higher to what we see in Peru and in many other cities. Do you think we can find a way to make people see Baja California as a separate entity from the rest of the Mexican territory, and so it could be eligible for getting resources for this? If we don't do it here, it's going to be so difficult. No, I totally agree with you. Mexico is a very particular case because it has a third of the states have low incidence, a third part of the states have mid incidence, and we have the other third part of the states, they have very high incidence. So the first thing we need to see to do advocacy to allow federal states to allow states considered as separate states. It's not easy because the rule right now is this, that we cannot see them as a separate entity, but advocating for because in Mexico, we don't have very high incidence, but we have realities that show that in some areas, the incidence is super high. We need to figure out a way. The problem is because some of the states are also poor. It's not the national mean. It's the same average. But some states, they have high burden. And some other states, they also have very bad economy. So maybe the federal government may advocate for this, but this needs to be at high levels of the political sphere. Because Baja California can say, please just help us. That's it. No, we need to find collaboration. Because this is not only the case, not only applies to Mexico, there are some other countries around the world that present the same situation. And then maybe there should be a way. It's not an easy task because in recent years, instead of maintaining the rate has been going up. And even though we have all these efforts and national and state program, they work properly and they're doing their job and they're doing their best to control and to do follow-up treatment and diagnosis of all patients. Now, with the caravans coming, the immigration caravans, and all this high influx of people here has very particular characteristics. So we are next to the U.S., who are very interested in controlling this disease. So it's a big concern because it's going up. So the question they ask you about AI technology, and I don't know if you remember that we talked about how we could implement the active screening of active cases in here, because it's hard because of all the movement of people we have in this area. So what can we do? How can we do this in order to control this? Because there's got to be a way, for sure. It's a very difficult population. In some areas, it could be almost impossible. Very difficult. In Europe, we have the same problem. In Rome, the countries, European countries such as Austria and Germany, who are rich, it's impossible because the Romanians, they travel all the time. They never stay in one place. Children, they don't go to school. So it's a population that lives in the medieval reality from the Middle Ages, almost. Because no one in Europe has found a solution for this. Because people even moved by horse. They commuted by horse in 2020. They commuted by horse. So it's impossible to control this population. So it's an example that will create frustration because everyone feels frustrated because this is not possible. But we don't have a solution yet. It's clear that as such a situation we have in California, Baja California, may find some solutions through the collaboration with the US, but I think the initiative, your initiative is the right initiative, which involves the collaboration, the cross-border collaboration, and that can be a lot can be accomplished through that. So generally speaking, around the world, which country or countries can say that they have been able to control TB in immigrant populations? Is there any country that has been successful? Yes. Right now, countries that have a good working model are those countries in the Gulf. But this is a specific immigration. It's not because not immigration due to poverty like in Mexico towards the US. It's this kind of migration is working migration. Migration of workers, they migrate to those countries just to work because those countries pay well. And those countries have very particular situation where in Qatar and others that for a person born in Qatar, there is 5 immigrants working in the country. So this immigration, when they come to the country, they're going to stay there for maybe 1, 4, 5, 6 years. And that's it. They have a contract for that. Migration is being regulated. It's not just a wave of immigrant people coming in. The number is very impressive because local population is wealthy. It's also very small. They have a lot of money. They can build a lot of buildings and do so many things. So the results have been great, but this is an easier type of immigration because it's being regulated. Some other countries where it's very difficult, for such as Lebanon. Remember, I showed you the picture. All these immigrants, they moved because of the Syrian war. It's very difficult to do much for them because millions of people, a couple million of people live in the field, and out of those people, many are victims of human trafficking, human traffickers. So they organize those boats, and 20-30% of those people, they die in the sea. It's very difficult to do some things in the fields. I don't think that the strategy should be building walls. That's not the right strategy. The strategy, it means, would involve the collaboration and discussion among different parties and investing on both parties, collaborating, working together. It's a very big problem to be solved, but we better discuss this. We should not build walls. Yes, I agree with you. Walls are not the solution to this problem, for sure. Thank you, Naro. Thank you, Dr. Giovanni. I pass the floor to Dr. Francisco Gonzalez. Thank you, Dr. Giovanni, for your such great presentation. Truly, thank you. I think all the questions have been answered. And we want to thank you again for being here in such an important forum. Now, for this virtual international forum, we have been sponsored by two sponsors, Mambo and Nissan. Thank you so much to these companies for helping us develop this academic event. Now, I will introduce Dr. Fátima Luna. She is director of the Micobacteriosis program from the National Center of Disease Control and Prevention Programs under the Mexican Ministry of Health. Please, Dr. Fátima Luna, take it away, please. Yeah, thank you. Thank you, everyone. Thank you so much. So let's begin. I'm here to talk about epidemiological overview in Mexico. I would like to mention something. It's not only the epidemiological overview on the situation here, but we're also going to talk about the programmatic approach for TB. We need good surveillance for this. So I modified a little bit. I just modified a little bit the subject I was supposed to talk. I have a few minutes, so I'm gonna try to go real quick. So first of all, the purpose for this National TB program network is to cut these transmission chains. So we're only going to be able to do this through the right detection and treatment, strengthening the compliance with treatment. And we have discussed this in different forums. And this is not only a shortened treatment supervised by the healthcare providers, it could be supervised by anyone. That's something we want to accomplish through this program. Also, the context study is very important. When we have on the COVID-19 pandemic, we identified that many of the activities that we did through the program are very effective. And unfortunately, despite all the time that we have been dedicating to this, we have not been able to be entirely successful. Also, we need to talk about LTBI cases. We take this into consideration, but unfortunately, we haven't been able to convince the healthcare providers to treat an infection that shows no symptoms. And also, we need to convince the population of taking this. Just give me a second, please. I'll be right back.
Perdónenme, se me fue un poco el audio, perdónenme.
Sorry. And also periodic evaluation. We need to assess the person who's been affected by TB through a multidisciplinary approach. And also healthcare, we should also focus on the person and not on the healthcare system. That's fundamental, something we tend to forget, not only for TB, but for many other diseases.
Este programa de acción específico tiene un fundamento.
This action program has this basis with a consideration in the national constitution. And we also have international organisms that work together and help us define a strategy for TB and the international guidelines for healthcare. Also the laws within the Mexican territory. Was also internal guidelines for different institutions in Mexico. And obviously, we have an official standards. We see the 006 requires needs to be updated. Despite the fact that we have been put it on the agenda of the decision makers, these are being updated periodically but they need to be updated urgently. So also as part of this is part of the 2024 health program. Where are the resources coming from? Okay, we have a very good intention, very good will. We have that budget, it's impossible to actually do this. TB. We have the 009 with the budget allocated for this. This budgetary program is just a little bag that everyone is getting money from, and the general epidemiology direction gets money from this. So basically, this national program takes resources for human resources. Like in Mexico, we have between 16 and 20 people only under the payroll because of Senapress. Through Senapresses, and usually they're directed at health promoters. So our state leaders are paid through the Ramo 33, which is a budget that is available in each state. And of course, each the state ministry of health, they decide how much money will be allocated to TB. In a not less important issue, which used to be Seguro Popular, Popular Insurance, and Insabi, they have a budget, allocated budget that is 32%. And this 32% is very important because 32% is what public health department gets. So we have all these vaccinations, we have all the different specific actions, generic equity department, and so on. But we all cover under this 32%. So it's difficult to rethink our system, particularly when our state leaders, they are not familiar with epidemiological overviews and they don't know the actual situation, so they don't take this as subject to be included in their agenda. So it's fundamental that the decision makers are aware of our situations. So this graph was presented. You will see on the left some of the goals that we had and that are targeted at the ending TB is reducing incidence rate, reducing the number of deaths, and also the reduction of catastrophic expenses. So here we are also adding the goal of improving the therapeutic success. As you can see on the green line, we have all this therapeutic goal. Yes, about 80%. But we have had some problems, especially after the pandemic. We all know that not only COVID-19 was affected by TB, but not only TB was affected by COVID-19, but many the reduction of the incidence rate. You can see on the blue line, you see that we have been on a flat line. We have had many forums, but unfortunately, this flat line throughout the time is telling us that we haven't done necessary activities to actually turn around the attention to TB. So today, when we talk about this behavior, thinking about prevention and controlling the situation, and also thinking of future evaluation is very, very little likely. Mexico, especially if we do the analysis, or we continue having these approaches between what is estimated and is notified between 20 to 30%. That's a gap every year, meaning that we are leaving 2 out of 3 persons without undiagnosed in Mexico. If on top of that, we add that most of the presentations, not only in Mexico, but throughout the world, are for long conversation because it's one of the major we have a problem in this regard. And it's impossible to think right now on dropping the incidence rate, especially because if we allow me, we'll be using just giving the information. The fact that you are not notifying, that doesn't mean that there are not cases. There are some undiagnosed cases, and what we're presenting right now is we're going to try to find a way to be able to increase the screening efforts and measure this active effort. And Dr. Ivani just mentioned, if we need to be active in the population in Mexico, we're going to see this on the chart. But it's important to know the prevalence of these situations. And diabetes, according to to the last survey in for national health persons is 10.4 prevalence. So diabetes is not a minor issue. It's something very important to be taken into consideration, and it's particularly more important when we see how this relates to TB and mortality rates. Yes, we have had a good success. We dropped this even before the pandemic in Mexico, unfortunately, through COVID-19. Even though we was not had a big impact on us because we don't have much money available anyways, but we, for instance, the lab availability and the drop of all of the yeah, we didn't get all the supplies needed for this because everything was stopped due to the pandemic. And it happened not only in Mexico but around the world. And the notified cases for 2021 in Mexico were 22,429 cases. And if you see on the left, you can see that throughout the years, we are really trying to increase that incidence rate because that's what the estimation bridge gaps that we mentioned, and the deficit in the contact tracing efforts. Also, you see in 2019, we had a drop of cases, and that's not because we want to, achieve this drop in the incidence rate in comparison to 2015, but it's basically what I was telling you with COVID-19. That's why we saw less cases. We have 1 out of 4 people in diagnosis undiagnosed in Mexico. So it's important that we start resuming these other activities, of course, to trying to protect the health of our staff. We need to make this effort, trying to promote self-care practices in our staff and throughout the population in general. In the case of the city, we have some new cases, but we assume there are sensitive cases. And we assume they are sensitive because of the diagnosis and the lab techniques that we use is vaccinoscopy. That this does not allow us to visualize from the very beginning, at least if they're variable, sensible to vaccine. And same, likewise, it does not differentiate the kind of microbacteria that is present. So we just assume they're sensitive due to the clinical follow-up and bacteriological follow-up with these final classifications. So 9 out of 10, almost 9 out of 10 people, 88% are new cases that are assumed to be sensitive. Unfortunately, we have new resistant cases in some areas that we have identified in some communities, and these strains. And this is very important because there are different factors for this. First of all, the contact tracing with treatment for those cases for drug-resistant cases in Mexico is something that has been a proposal that unfortunately we haven't been able to put in writing, and that's we have not been able to do this kind of activity, especially in some of the institutions. The request is these regulating documents to be able to have a good estimate for drug-resistant strains. And though we have also tried to buy the medications for this treatment, but it's necessary to have the changes in the regulation to remove all the treatments and diagnosis. Something that is all regulation. It has a very big burden on this, but we need to change that. We need to have a living document, a guideline. And while this happens, we need to try to take this down to some other instances and like committee that we're trying right now to be able to find a oral agreement, and so we can start working on this, approved and supported by this organism. And also we have cases, privileged treated cases, 90% of all the cases we have, despite the fact that in Mexico we have a platform, a real-time platform to the operating level. Unfortunately, the data quality has a bad impact on this, especially for us as the managers, only 77 people, because we're talking about people, 77 persons that we have here that are blank. We don't know what we have to do about this. We need to buy, document the first line drugs, second line drugs. We need to be more accurate lab cases for in case if we have a drug-resistant TB cases, and what kind of treatment we're going to do to the trace to contacts and so on. So it's fundamental for us that we're getting all these trainings and all this information. We need to replicate this so that the person that is facing the patient that deals with the person patient in person, they should have all this information. We should cascade this information. Dr. Muñoz mentioned about Baja California because I've heard her mention this in different forms. Baja California is a serious situation in Mexico. We actually worked on the major hotspots in Mexico. We will reduce this problem greatly throughout the country. Unfortunately, there are different circumstances that keep us from doing this, or they have been keeping us from doing this. Not only for us, so the national, by national and state programs, but different actors that have been trying to get involved in this. We have seen in Baja California two active projects that we have only tried to add resources. And resources are very important, fundamental subject. Without resources, despite even if we have all these experts and documents that will allow us to do some activities, because if you allow me, I mean, we cannot achieve much just with goodwill. We need resources. So as I mentioned, with this epidemiological surveillance budget and all these big decision makers, I don't think the TB is a major situation. So they don't allocate the right resources for this. So today we're having the sixth meeting for establishing strengthening plan specifically for Baja California, even though we have a specific program in national program. Baja California has very specific circumstances, and we need to take all those into consideration so we can actually make an impact. No, it's not going to be a change it's going to happen overnight. If we have this plan is effective, we're going to see the results in 5 years, but it's fundamental to take control of these situations with high burden of TB. So right now with these new strengthening plans, we're working on the healthcare system and international organisms such as the UPS office in Mexico, Canadice, CIDA, and also the ministry, the office for the elderly, and of course the state government. So we're trying to take all these activities that will be targeted at changing the incidence in Baja California. So we're talking about the incidence rate, and nationally speaking, it dropped also because we see less cases where we're going back to what we mentioned in the baseline, and what we presented from the program is to increase the incidence rate, not because we want to have more cases. Of course, we don't want to have more transmission, but no, we're trying to identify all those people that have been undiagnosed. So basically, we see this in working population. This is the average of contacts we see for each case. It's about 2.5 to 3.5 contacts for each case that we see. Fátima, who's part of, if Fátima caught this disease, she'll probably have 3 contacts. I have counted them and I've seen that even 20 contacts between family, friends, and co-workers. It's impossible to have only 2 or 3 contacts. So since we're not taking this or not giving the right importance to this situation, this having a negative impact on this. It has not allowed us to actually achieve our goals, national goals and global and international goals. It's basically most prevalent in men. Children under age, there's 240 kids they have that we have identified. they have had some. I was talking to the investigation network, the research network, that if we add all these intermittencies in the last 2 years for the application of ABCG coverage, this interferes with the situation in the presentation. Pulmonary TB incidence is one that we usually see, and it goes up and down in different states, but generally speaking, it maintains steady. These rates tend to go up or down, especially for. But if we divide them by age group, we see the elderly, they are more affected by this. For meninges, tuberculosis, there is not a behavior that we'll have to see in PTB. But I'd like to mention something for children under 5. In 2021, we had 14 cases of meninges TB in children under 5. We know the complications for these children. Many of them, even if we do the diagnosis, we see in the contact tracing efforts were very weak. And we have an index case that they didn't go to investigate the cases active in the families, and the excuses that we see for these contact tracings are very weak. The fact that they say, okay, no, he doesn't live with the index case. Yeah, but the person visits this person, so also we add to the fact that these children were not vaccinated because the vaccine was not available, then we are increasing the risk for transmission. The location is basically in the lung. 8 out of 10 people here with TBC is pulmonary TB, and also extrapulmonary is seen in other people, especially people living with HIV, meninges, TBs, among others. And the diagnosis. Unfortunately, we're still doing this pulmonary TB and second and third level clinics. So what's happening at first level? Yesterday, we talked, we have trying to have good coordination with the first care providers.
Nacional, estatal, jurisdiccional de tuberculosis. Porque a veces se queda ahí la información.
Sometimes the information just stays in documents, and we don't cascade the information down to the front line. So this we should have good communication among different levels of healthcare system, and we try to provide trainings to all the different actors, especially those who are at the front line, as I mentioned, that are right there dealing with the patient directly in person. And just finally, the Ministry of Health is the entity responsible for notifying in this case 62%, but this is the army that tend to be used in the country, and they move around the country, even though they are a very small group. We should have more cases, particularly because they go to high burden states. So we also try to strengthen having a good active screening among these populations that very infrequently are screened. You can see the detection service, yeah, external consultations, yeah, this is the second and third level of healthcare. So pulmonary TB, we have all this, most of them are being diagnosed in the third and second level. Unfortunately, I think we think that all the diagnosis should be done at the first level of care. So we just happen to have the diagnosis opportunity when finding these vacilloscopies where you can see half the cases will have completely this criteria. When we classify by states, we see that there are states that have only 31% only of vacilloscopies, double cross, even then triple cross and reach 40%. So how far are we reaching? How far are we going to diagnose our cases, TB cases? Dr. Giovanni talked about the comorbidity association and all interactions with different drugs, having a good control of the base disease, among others. Those factors play a major role in the success or the lack of success of controlling TB. And this is a major situation for us. We're talking nationally speaking, we see prevalent cases that we knew that they were diabetic, because diabetes is a major problem. 30% of those cases are people, and the tuberculosis, 30% of people have diabetes mellitus. So we're talking about drug-resistant TBs. We see half of the cases, resistant cases with some sort of resistance. In addition to that, they suffer from diabetes. So this makes things a lot more complicated, especially for the administration of the pharma for the drugs, especially when there's a drug-resistant TBs. So these drug interactions are very frequent, and we need to address this. But it's hard for us to find a good treatment and with good compliance. So yes, we want to learn about resistant TB, but we should learn how to treat well sensitive TB. We need to treat sensitive TB first. People living with HIV is similar to what we have for worldwide, 7 to 9% in Mexico. And the combinations we have. This is a little note that gets us thinking. 67% of all the cases, they suffer from at least one chronic disease. Your nation, Fátima suffers from diabetes, and she also lives with HIV, and she smokes and drinks alcohol. So we see a number of conditions that will not allow us to have good compliance due to their addictions or the other comorbidities, etc. All this makes things more difficult for treatment compliance. In the case of the program, we have this trend that we use screening for diabetes and HIV. Throughout the time, this has been going down, but it has to do with people that are known cases, prevalent cases for this disease. Now we don't do this screening because we all know that. It would be irrational use of the resources. But if we talk about with people living with HIV and prevalent cases, we're talking about 7 to 9%. And we also use the incidents that we assume that are reactive and that probably will be ratified. Then HIV cases is 10.4%. And we talk about diabetes, we're talking about 30%. We add on top of that 5% extra for diabetes mellitus. Again, we have been talking about this for a long time. We have large areas of opportunity. We have all these groups, support groups for diabetics, different programs for against diabetes, and the senior program. We have been able to approach different institutions and the population. We are working with all the different institutions so we can try to have active screening for TB for patients with diabetes. Also, in the survey and the risk survey for chronic diseases, we always ask, do you suffer from cough? And if so, then we ask some more questions for diabetes. And also the registration and control diabetes card, where we update these cards when they go for their follow-up. We update their information. It's also one of the variables considered in this part of this program. Also, documents may be available, but if the decision makers or the doctors are not convinced of this importance, it will be impossible for us to get where we want to be. So we're just rethinking how we can have our leaders together for diabetes and tuberculosis leaders, so they can start having this kind of communications. We can come up with trainings for both programs. We have some risk groups. There may not be that many, but they're very important to all the different activities. Indigenous populations and the people in prisoners. It's very important because we only see them and we forget about the bridging community. Yeah, because this is a very important issue. The incidence rates can be 100%, 100 times above the average rates, considering all the different characteristics within the jail system. And also we are looking at about the mobile system and also the bridging community, those who work there, the guards and so others and doctors and many others. when they go in and out of facilities with high burden of TB to the outside world. So it's something that we are working on. We have approached the prison systems, federal prison systems. We gave the first 2 training sessions for their medical, for the doctors, and we established the communications with the closest healthcare systems, also the national cases. And the north part of the northern border is very well known. Well, we are not working with the same impetus in at the southern border. We're waiting on Foreign Affairs to see how we can work with the south part of the border of the country. And also we talk about pregnant women with TB can be difficult, especially because public healthcare staff, they don't know what to do with a pregnant woman with TB. They don't know what the consequences could be on the baby. The examined cases, as I mentioned, about 20,000 cases of TB is the average in Mexico. I'm sure that we have many more. These are the declared cases for 2021. These are the ones that we declared. I said, okay, this is the number of people that we declared. You see, 65,948 declared. And this can change in all the different entities. So if we're never going to make the change we want, if we don't work on this, now on top of this, we only are examining the situations on how the person is right now. This is the concept for this, only 85% when we have at least 6 months during the treatment, in 2 years after being remission from TB. On the cases we see in this kind of secondary cases is 0.5, only 275. So what's the quality of this attention of the healthcare we're providing? And how much we are paying attention to the context to make sure there are not Latin cases among these contexts. And also we might forget about the primary cases. It has happened before that we have someone who's coughing at home, and then the dad comes in and see that we see different family members here, but we don't go to the original case in the family that has been explained. So we're talking about children under 5 years. We're talking about meningitis, tuberculosis, and then these sessions, the screening sessions, when we ask for all the different arguments of what happened with this child, so we can intervene and make sure this doesn't happen again. And we see that contact tracing is very weak. What happens if we don't do? How much time will be required to make sure that avoid children from catching this meningitis, tuberculosis, Tida, and the therapy we are providing for TB cases in Mexico? It's been for a long time. With among all the documents we have, the LTB eyes and the treatment, everything is right in paper. But how much success have we achieved on the success for this? We need to make sure that we have the right contact tracing, and also make sure that the treatment works well. And we have actually worked on this. We've seen some successful. Some states, they don't want to buy PPG because they no, you know what? I don't want to buy PPG. Because Inicidas is coming with estimates based not on their baseline that they mention is the historical. How much? No, what's the need? What's the estimate? The estimate is based on the people who are part of these risk groups. So we're talking about historic, and we don't confirm this. We may have even less biopsy of this drug. So we need to first convince our TB leaders. So unfortunately, sometimes they're not very convinced of this. Second of all, we need to empower our healthcare providers. Likewise, I've heard many of them say that, okay, if he's not sick, the patient is not sick, why giving them the treatment? They were not convinced, and we are We may have all the tools, but we were not going to be successful. The importance of treating LTBIs is so important to avoid reactivations in the future. And also the population are not aware of TB in Mexico. And we have seen this. We just had the rabies vaccination campaign, and there was a lot of information, but we haven't really talked about this because they only talk about tuberculosis on March 24th, but this is a subject that should be talked about all the time, especially in those high burden cases in Baja California. Out of all the people in Baja California should know I've been coughing, and this is a serious situation in my state. I should go see a doctor and make sure and test for TB. We should be. I'm going to go a little faster. So our cohorts, the treatment cohorts for TB, for pulmonary TB cases, we see the case of the success of the treatment. Unfortunately, we put together healing and in terms, yes, sometimes it's the lack of supplies. We cannot do bacilloscopies, but instead when you see an arch on the lab, when you have all the resources available, the healthcare providers in that facility, they are not aware of the importance, and they don't know how to do the right follow-up for these patients to make sure that this person is responding to treatment. We have seen that in some situations when we don't have bacilloscopies and said, okay, we did a culture at the end. Yes, you were lucky, then maybe you got a negative result. But what if it's positive after the 6 months, where you could have since the very beginning been able to identify the situation with a positive bacilloscopy? You would have been able to do something for that person, not wait for after 6 months. There's a reason for everything within this program. But if we don't explain our operations, operatives, then why we want this, we're not just inventing things for the sake of it. There is a reason behind, and if they're not convinced, we're not going to be successful. Nationally speaking, the success to treatment dropped to 80%. And we say we're within the guidelines, 8 out of 10 are successful in Mexico. Ideally, having all the resources available, all the supplies, and all the people trained for this, that see the patient at least once a week and verifying the compliance with the treatment at home and their communities. If they are not, you can see them on a daily basis. Unless we need to make sure we have some bacteriological follow-up to make sure that we are actually healing these people. We talk about the mortality rates is similar. They don't cure. They especially occur in the end of life ages. We see. Despite the fact that we have a lot of healthcare professionals that are committed to TB, if we don't have the right conditions to conduct all the different activities and actions we want to take, we won't be able to see a change in the behavior of this disease. That would be all on my end, doctor. I don't know if I have any questions. I'm going to stop sharing my screen. Yes. Thank you so much, Dr. Luna, for your presentation. Dr. Fátima Luna, thank you so much. A great presentation. Once again, we want to thank the sponsorship from BACMO, Bizan, the data, the contact information on these companies you can see on the screen. And now we're going to move on to the questions that we have been receiving from the audience. The first question is, in addition to the vaccine, BCG, and the contact tracing, is there any other strategy being implemented for reducing meninges TB incidents? Yes, we have been training staff. There is an important situation here. especially for the specialists in hospitals. We're just waiting on bacteriological prevents. We're talking about therapeutic response. That we have forgotten about talking a bit about this, and we cannot start treatment if we don't have this. We know also that the early stages of treatment is crucial. If we are with a child under age in Baja California, we have the background that there is being contact from someone that has meninges signs. Then you should think of tuberculosis when about syndromes. Tuberculosis is one of the meninges syndromes, so it's important to think about tuberculosis right away. We just had a session with all the state leaders where we want to make sure that we spread this information among all the healthcare staff to think of tuberculosis where you cannot be seen, will never be found. Think of tuberculosis, think of meninges tuberculosis, especially when you have these variables around it. The intermittence in BCG intermittent and changes states with high burden of TB. And the epidemiological background has a reason for this. We just forget about it. We don't pay attention to this. So these activities have been taken from the program, and it's a very important situation and a point for us. In addition to that, we have pediatricians throughout the country. We have Dr. Sadia, Dr. Lucy, among many others. They are volunteering for providing counseling or advising healthcare professionals for this. Yes. Personally, I'm a pediatrician. We have seen very frequently cases with children with meningeal syndrome that have been treated for many other conditions. Some MRIs have been done on them, and the last thing they think of is TB. So I think we need to put this more in people's minds, make them aware of the situation. See, the TB is a prevalent disease, and it's right there, it's present. Because a lot of people think that believe in the myth that there are almost very no cases of TB in Mexico, which we know is completely false. And we need to create more awareness among the healthcare providers and even among the families and pediatricians, family of the patients and pediatricians. Yeah, and also I would like to use this time. We have available that can be used that we bought from the Ministry of Health, and we have asking all the state leaders to distribute these medications we just bought. We should also spread this information about to tell all the healthcare providers to know that we have these medications, drugs available for pediatrician patients. So because we have the right drugs for children, and people should be aware of this, so they take advantage of all this medication we have available. Okay, thank you so much. Another question, and in Latin American countries, they have done some screening on prisoners. We have identified an incidence of many cases of multi-drug resistant cases. Is there any strategy for this risk group? And if you're going to prioritize these cases, because many of the cases they have multi-drug resistant TB infections. Well, the behavior is different in Mexico. We have less drug resistant TB in persons. Fortunately, otherwise the case would be terrible. Well, we know, for instance, in Salvador, they have a very good program for prisoners, but also we need to remember the budgets we have available here, and we also need to direct your efforts to one place. Okay, yes, definitely, prisoners is a very major issue for us, and we are seeing how we can work together with the prison health system, so we can work together. It's a different world. The fact that we don't have access, physical access, how we can go into the prisons to help them. We need to tropicalize all these efforts for this penitentiary system. For the supplies and the labs, it wouldn't be such a problem, but they have very good results. And we have seen this, we have analyzed this. Dr. Yvonne was part of the effort, so she was in Colombia, and we saw this. Yes, they have very good healing rates. Yes, but what happened with the floating policies? We're not only focusing on prisoners. We need to see on other people that work, that live there, people that work there, because you have very good compliance and treatment because they are there. You cannot not comply with the treatment because you have them there captive. Yeah, it's a made success, because what happens with the people working there? So we should have a full analysis of everything that happens with all the people, with the prisoners, but also the workers or the prisons. Mexico, unlike many other countries that receive money from the international support, and they have been trying to work on the portal mobile X-ray machines and on the screenings in Mexico, we don't have those things. We are a country that consider we are too rich for getting these resources, and this not allows us to do all this. So what are we trying to do through our national program? We're trying to get budget, not we just want to come here and say and complain, we don't have money, how can we solve this situation? So we're going to the House of Representatives and the Senate to have a tagged budget. So with the 3 pesos that we get, no one is going to touch this money, because it's happened before that, I don't know, there is another disease, disease starts acting up, and then they take our money for treating those diseases, and that's not right. Yeah, unfortunately, we are right there in that position. We're not candidate for receiving support, for receiving resources, but we don't have enough money for starting those efforts ourselves with our own resources. So that's where we get stuck. We're stuck in the middle because we have the problems, but we don't get the help needed for this. Another point is that, so another question is, in addition to PPD, you think that we could try to use iGrass for this? Yes, now we already have a project, and we're about to launch another project. We're trying to measure the LTBIs. When we talk about iGrass, well, there are many situations, but operatively speaking, it's not feasible. Well, when you have a very limited resources, when you have to buy little, I don't know, cartridges and medications and so on. So what we can do here is, with this operational research, we're going to be able to target this iGrass, maybe for children under 5. We don't have the end results yet, but this will allow us to establish this. PPD, luckily, it comes with a stigma, but it's working very well in Mexico. We just tend to think that, okay, we are BCG vaccinated country, but remember, the vaccination has, or the immunization has sometimes said after 17 years after being vaccinated, you don't have PPD issue. So it's been done. We're going to be visualizing this, but we'll be basically on some risk groups. Specifically speaking for immigrant population, is there any strategy based on the presentation by Dr. Migliori as a strategy for immigrants within our country? There's an active consensus of how many people, immigrants, are being infected with TB, and how many of them are under treatment. We don't have a census, remember? We have a platform where all the people that live, or they're in Mexico, they don't talk about only about Mexican population, but people that live in Mexico, they receive treatment for free treatment for TB. We have Casuistica. This platform allows us to know how many cases we have every year, where they are from, and the classifications, and strategy for immigrants will be doing this screening. But here, in just from the human rights, because sometimes you just want to go, even these campaigns want to go there to do some health activities, but people don't allow this because they see this as a threat. They say they're violating their rights because they think that since when they are diagnosed with something, they won't be able to cross the U.S., which is the end game for all those, for the final, their purpose, the ultimate purpose. So yes, it's a difficult situation. We see this with the Ministry of Foreign Affairs. Yeah, many ideas have been floating around, but nothing has been followed up. So we had we see that there was an effort, but nothing happened there. We had a card, a vaccination card, but no immigrants were using it. So there's a problem with migration because the immigration office will not allow us to do many activities in order to protect the immigrants. Okay. We have some research on TB in immigrants, but we need to, more needs to be done. Or they're asking if there is some research on how immigrants were infected, and if there is a contact with infected animals with TB. Yeah, I don't know if you heard about Uma Salud. We are checking zoonosis. Dr. Muñiz herself, she's worked on this, and we went through this once, but this has been paused a little because since there are actors actors outside the Ministry of Health, then we need to have the coordination with the different ministers. Senapres is working on this. We are trying to get a green light for this. And as for research, well, as you can see, we have a research network with our president, Dr. Rogelio Hernández Pando. We are trying to come up with an agenda to create a research agenda. What are the priority subjects for public policies in Mexico? Not only publishing, yeah, that's very important, it's true. But what we want, what's fundamental is to create evidence to generate public policies. So it said that it has been mentioned throughout the practice, constant and permanent training for healthcare providers. What do you think is needed to make sure that these trainings are more effective? Yeah, we need to measure knowledge because we can be present, but doesn't mean that people are actually learning the ideas. And so it has the logical learning techniques. So we need to find a way to make sure that people are actually learning what they are supposed to learn, and to verify how we can know the person that is sitting in front of a screen is actually learning and not just being there because they told them that they have to be there. So because people can just turn on the computer and they just go away and not pay attention. That applies to everything. And also I have been in the operational and the operating team, but we need to see when I was a resident, when I was visiting different communities, I had to learn, okay, what kind of disease is prevalent here? What kind of virus is circulating in this region? So it's important for us to take an epidemiological subject as something fundamental, and it needs to be personalized to each, customized to each community. I think it's necessary to strengthen academic programs for the human health degrees. Of course. Yes. yesterday. Thank you so much. We discussed this yesterday. Many of the things that we discussed yesterday are being brought up here. Dr. Wine disease, he actually, Dr. López Gatell commissioned this. They were checking the curricula for these schools. That's how many of us went to college and we saw tuberculosis, but we never knew what was the behavior of TB in Mexico. But it was not until I got as an operator, as a general doctor, I realized that there was TB, and that's why I started working on this. So it's fundamental to talk to the universities. Dr. Muñiz, has this subject. She teaches TB in colleges, especially in Baja California, Sonora, Sinaloa. Okay, what are the endemic pathologies? And based on that, you should emphasize during the curricula, as part of the curricula in colleges. And lastly, there is the official Mexican standard 006, and we see that there might be some areas of opportunity. According to your experience, what would be the areas of opportunity that we might have in this? Okay, let me tell you. We already have our proposal from the national program. We just need the green light from the authorities to do this. What are the proposals we have? I guess you know the 011 for the rabies standard is a living document. Diagnosis and treatment is out of that, and they send you to the guideline. What allows you to do that? You can allow the guideline. You can have a living document, and a regulating document is great. So that's exactly what we want. That's exactly what we're trying to do here. Let's take everything out of the standard. Let's leave the guidelines, how things have to be done. Well, the reference documents and the guidelines, yes, let's include everything. And secondly, we're going to have a unique guideline because in the program we have like 3 different manuals. There's so many documents. We condense that, unify that in a single document to facilitate the attention for the patient. The microphone was acting up. Oh yeah, it was muted. So once again, I just want to remind you that we have here the sponsorship from Multisan, and you can see the information about these companies on the forum page. I want to thank Dr. Fátima L for her great presentation. Thank you so much. Thank you so much. I think that all the questions have been answered. The presentations have been very clear. And we're just gonna thank Dr. Luna. Now we are going to share some information for the next forum, for the next session next week, Thursday, October 11th, 11 a.m. Pacific time. 9 a.m. Pacific time, 11 a.m. Central time. You're gonna find that information on our website. Or we're gonna next week we will have Dr. Alberto Mendoza, who is a researching document for the emergency in Villa Salvador in Lima, Peru, and with the subject thinking strategies for TB and situation and the drug-resistant TB situation in Peru. We also have the participation of Dr. Rafael Amiado Lamorin, who is the head for the clinical laboratory for TB at the General Hospital in Tijuana, Mexico, with the presentation Mexico, comprehensive management of drug-resistant TB. Thank you. I'll pass the floor to Dr. Oh, I apologize. It's gonna be on Tuesday. I said Thursday, but it's Tuesday, October 11th. Yeah, the same time, 9 a.m. Pacific time and 11 a.m. Mexico City time. We invite you to be here with us to join us. Now, Dr. Raquel Muñiz, please take it away. I want to thank you, first of all, for having me, for the invitation, for moderating this event. Thank you, all the speakers, and Dr. Giovanni, Dr. Fátima, thank you. And also thank you, Dr. Gonzalez, for participating as moderator for these sessions. Thank you so much for your enthusiasm, and you're always willing to help and collaborate with us. Thank all the people, the audience members, for following us on the different channels, YouTube, FoVI-TB, and Facebook. We also encourage you to share this link. If you haven't enrolled, please do it. Do it on the website, www.remitv.org. We will be waiting for you next Tuesday. Thank you. And remember that TB is treatable, is curable if it's treated on time. Thank you so much.
Listo, ya estamos fuera de aire y están ahorita los patrocinadores, los videos. Para cerrar.
Sí, sí, está bien. Déjalos ahí unos minutitos, unos 2 minutitos, yo creo. Que
Ok,
sigan.
está bien, maestra. Está bien.
O sea, sí, se sigue transmitiendo, pero ya no se sigue transmitiendo el...
Raquel, la grabación.
Así es, teacher. Ya ustedes ya están fuera del aire y ahorita están los puros comerciales.
Recording stopped.
Ok, ya la paré. Gracias, Ever. Ok, o sea, nosotros ya no nos escuchamos.
Ya no, maestra, ya no. Están fuera de transmisión. Puros comerciales.
Están los patrocinadores. Sí, déjalo, yo creo que unos 4 minutos más.
Ok, está bien, teacher. 4 minutos.
Unos
4,
2 videos. Pones el video de uno, luego pones el video del otro, luego otra vez el uno, después el otro y ya.
Ok, teacher. Sale, vale.
Ok. Muchas gracias a todos, querido.
Gracias. Hasta luego.
Thank you. Very good.
Gracias.
Aplausos a todos.
Gracias, hasta luego.
Gracias.
Felicidades, muy bien.
Muchas gracias, Francisco.
No, a la orden, ya sabes, lo que se ofrezca. Aquí
Sí, y sorry porque yo me equivoqué, porque yo te puse jueves.
Sí.
Y por ahí ya me corrigieron y pues ya por eso te
No,
dije.
pero sí alcanzó a salir la corrección a tiempo.
Sí. Ok.
Muy
Pues
bien.
bueno, entonces, pues les pido de favor que sigan compartiendo en las redes sociales, hay Instagram, TikTok, Facebook, WhatsApp, todo lo que tengan, OnlyFans, dijera Eduardo.
Manden la liga, por favor, para darle difusión. Gracias.
Gilberto dice que también tiene OnlyFans.
Rogelio, yo lo vi.
Rogelio también, ¿no? Tiene seguidores.
Sale, hasta luego, buen día.
Ok, bueno, estamos en contacto. Gracias.
Buen día.
Bye. Sepa, muchas gracias. Como siempre. Thank you.
Ya sabes, mucho trabajo. Felicidades.
Muchas gracias, doctora. Pero vamos a seguir incrementando el número de visitas para las próximas semanas.
A difundirlo. Bye.
Exactamente. Bye. Gracias, Ari.